Hi, everyone. My name is Vineeth Sukrithan. I'm a medical oncologist at The Ohio State University Comprehensive Cancer Center in Columbus, Ohio. I specialize in neuroendocrine tumors here at Ohio State, and it's really a pleasure and privilege to be able to talk to you about symptom management and what matters from my perspective. I want to start by talking a little bit about this term that many of you may be familiar with called carcinoid syndrome, and we'll try to demystify it a little bit. So, carcinoid syndrome is essentially present in around 20 to 30% of people. Most commonly seen in small bowel neuroendocrine tumors, but not exclusively, with metastasis to the liver. Normally in our bodies, 99% of an amino acid called tryptophan is used by the body and metabolized into something called NAD, which is a chemical that's used in multiple processes in our body. But sometimes what happens is in patients with neuroendocrine tumors, up to 60% of the body's tryptophan is shunted instead to another pathway, which leads to the production of intermediates called 5-HTP, which is further converted into 5-HT, also known as serotonin, and finally broken down into a metabolic product called 5-HIAA. This leads to an overproduction of 5-HT or serotonin, which leads to some symptoms which we call the carcinoid syndrome. Now, these hormones are normally broken down by the liver, but when we have metastases present in the liver, the hormones directly enter circulation and cause a panoply of symptoms we call carcinoid syndrome. There are also other chemicals that do play a role in this process, like histamine, prostaglandins, and bradykinin. But the majority of the symptoms are caused by serotonin and its breakdown products. Let's start with flushing, which is one of the most well known symptoms of carcinoid syndrome. So, what is flushing? It's blood vessel dilation of the face and the upper chest, which can last from minutes to hours. Sometimes it's associated with redness and warmth, and occasionally there are certain triggers that can lead to flushing, specifically food containing tyramine, such as aged cheese, wine, spices, exercise, alcohol, and occasionally stress. Another common symptom associated with carcinoid syndrome is diarrhea. So, what causes diarrhea? It's actually excess serotonin, which increases gut motility, resulting in reduced absorption of water and electrolytes. And what we find is colonic transit time in patients with neuroendocrine tumors is shortened to 5 hours due to the serotonin effect versus close to 18 hours normally. And this is the underlying process of what causes diarrhea. Thirdly, is carcinoid heart disease, which is also a product of excess serotonin in the body. So, what it is, it occurs in around 50% of patients with carcinoid syndrome. It affects the tricuspid and the pulmonic valve, and it leads to damage of these right side of the heart valves, leading to symptoms such as swelling of bilateral lower extremities, abdominal swelling, fatigue, loss of appetite and weight, jaundice, and sometimes liver failure. Bronchospasm is another symptom associated with carcinoid syndrome. This is seen mostly in lung neuroendocrine tumors, also called lung carcinoid tumors. And the main symptom is asthma like wheezing, which sometimes can be confused for asthma, which can occasionally lead to a delay in diagnosis. So, what are the treatments for carcinoid syndrome? We'll talk a little bit about that in the next few slides. Somatostatin analogs are a frontline treatment. What they do is they bind to somatostatin receptors present on the surface of the tumor, specifically SSTR2 and SSTR5. And this leads to a reduction in some of the hormonal symptoms that we've talked about before. There are two long acting preparations of this, sandostatin and lanreotide. And as many of you may be aware, these are injections given every 28 days. The way they work is they inhibit the secretion of various gastrointestinal hormones, which can reduce gastric acidity and slow down GI motility and improve diarrhea and flushing. They are very effective. So the mean rates of symptom relief when somebody started on somatostatin analog is anywhere from 65 to 77%. They work really well for both flushing and diarrhea. So a complete improvement in flushing is observed in 50% of people, and more than 90% of people have greater than 50% improvement in flushing. As far as diarrhea is concerned, complete control of diarrhea is seen in around 1 in 4 patients, and more than 75% experience a greater than 50% improvement in diarrhea. So this is a very, very effective treatment to control the symptoms associated with carcinoid syndrome. That being said, there are some side effects worth knowing about. They are very well tolerated, and we know lots of people who have been on SSAs for long periods of time. But the side effects that I want to point out is sometimes SSAs can inhibit the release of other hormones, including ones like insulin and thyroid stimulating hormone. And diabetes can occur as a result of a reduction in insulin production. And we've seen this in somewhere close to 25 to 30% of patients. And the reduction in TSH production, which is a thyroid stimulating hormone, can lead to hypothyroidism, which is much rarer. But the literature suggests anywhere from 5 to 10% of people. So I make it a point to always have a discussion with patients and talk about some of these risks and what we can do to mitigate the increase in sugar that can sometimes be seen in patients when they start SSAs. There's also some effect on gallbladder contraction and bile flow. So potentially there is an increase in the formation of gallstones that we do see. Again, it's a small percentage of people over a long period of time. It is somewhere in the range of 5 to 10%, but it is worth discussing with your doctor before we start on one of these agents. So what do we do if initially you don't see an improvement in your symptoms after you've started the SSA? There is a lot of evidence that actually increasing the dose or the frequency, so instead of every 28 days, something like 21 days, actually does improve symptoms. So there was a study that showed that 80% of patients actually had an improvement in their flushing and diarrhea when the sandostatin dose was escalated anywhere from 40 to 60 milligrams instead of the initial dose of 20 to 30. So it's worth talking to your doctor about, whether you feel like the symptoms are not well controlled at the starting dose. Is there a role to increase the dose or the frequency? It's also worth remembering that there are many other causes of diarrhea in patients with NETs, especially when they're being treated with SSAs. One of them is actually a paradoxical diarrhea, which can be increased for the first 2 to 3 days after you get your shot. This happens in, again, anywhere from 30 to 60% of people. It's due to fat malabsorption that happens because pancreatic digestive enzymes are not being released to the same level when you're on an SSA. And this leads to fat malabsorption and a condition called steatorrhea, where stools can be fatty. The treatment for this is supplementation with pancreatic enzymes such as creon. Now, beyond that, there are other reasons for why someone would develop diarrhea. One is bile acid malabsorption. And this happens in people who've been treated with surgery, specifically surgery that has involved the terminal ileum of the small bowel or the right colon, or a cholecystectomy as well. And this leads to bile acid malabsorption, which can irritate the lining of the stomach and the colon specifically, and leading to diarrhea. And the treatment for this is actually a trial of something called bile acid sequestrant, such as cholestyramine, colestipol, or colsevelum. And a good relief with this treatment suggests that the bile acid was really what is causing the diarrhea. And finally, short bowel or short gut syndrome unfortunately can happen in patients who've had extensive small bowel resections, especially if the resections are more than 100 centimeters. So this is something to keep in mind in the differential diagnosis when you're experiencing diarrhea and if you have a NET diagnosis. More recently, we now have oral SSAs, so oral forms of somatostatin analogs that are in clinical trials that look very promising. So in phase 2 trials, the results showed that there's an improvement in flushing from a baseline of 2 to 3 times a day to 1 a day, an improvement in diarrhea from 3 to 4 times a day to 2 to 3 times a day, an improvement in the sense of urgency, which can be very distressful, from every day to every other day. And the results of this very promising phase 2 study are now being confirmed in a very large randomized phase 3 trial nationally and internationally, where the drug paltusotine is being compared to a placebo. This is an ongoing study. We are awaiting the results of this study, but we think it'll be practice changing once the results come out. And hopefully we'll have an option which is not an injection for the first time. Moving on to the third medication that is approved and is used for the treatment of carcinoid syndrome is telotristat, also known as Zermelo. So what it is it's a compound that inhibits an enzyme called tryptophan hydroxylase. This is an enzyme that is present in the body, which converts tryptophan into 5-HT, which is then further on converted into serotonin. So blocking this enzyme actually reduces the levels of serotonin and its products in the body. There was a large phase 3 study called Telestar, which compared telotristat versus placebo. And what they found was they were looking for a reduction of at least 30% in the bowel movement frequency from baseline for at least half the time that patients took it. And what they found was 40% of patients met this criteria for improvement as compared to just 20% on the placebo. So this is a good add-on agent for folks who are not getting a good degree of control with just the somatostatin analogs. Some caveats to keep in mind are It does take time for Zermelo to actually work in the body. So the median time for improvement in your symptoms can be anywhere from 4 to 5 weeks. And the pill does need to be taken at least 3 times a day with meals. So I try to counsel patients about some of these aspects so that they have a good set of expectations going in when they start this treatment. The fourth agents that I want to briefly touch upon are antidiarrheals like Lomotil and loperamide, which you may be familiar with. But what you may not be familiar with is some of the history of some of these agents, which is rather interesting and is closely intertwined with the Cold War. So the story actually starts in 1954 with the commission of this nuclear-powered submarine called the Nautilus, which was entered into service in 1954 by the US Navy. This was a revolution simply because when you have a nuclear powered submarine, it can stay submerged underwater for up to 4 months. And what this means is you can have a much larger crew on the nuclear powered submarine compared to a diesel electric submarine. But the corollary to that is you have a lot of people in a very cramped condition, leading to a lot of diarrheal illness. So the US Navy actually funded some of the first work in identifying new anti-diarrheal compounds in the 1950s. And that's what really led to the discovery of diphenoxylate in 1954, which we now know as Lomotil, followed by loperamide a couple of years later. What's really interesting about this is that this also actually led us to be successful in the space race because the Apollo space mission medical kits also had diphenoxylate in them. And this is actually a picture of one of those medical kits from the Apollo missions, where you can see diphenoxylate that was sent to space. Now, I want to switch gears a little bit to symptoms that are not related to carcinoid syndrome because they are also really important and they are worth talking about. First of them that I want to highlight is lower extremity edema or lower extremity swelling, which can be really bothersome and which can lead to a lot of stress for our patients. There are many reasons for this. It's a little bit difficult to pinpoint them, but I want to highlight a couple of them. One of them is everolimus. We use this compound. It's a drug that's used for treating systemic neuroendocrine tumors, but around 20% of patients who receive everolimus do have edema. So it's worth keeping an eye out for this and talking to your doctor if this happens when you're taking the pill. The other important mechanism is when you are on everolimus, there is an increased risk of metabolic dysfunction, specifically an increase in cholesterol, an increase in blood sugars and diabetes, which in turn leads to something called metabolic dysfunction associated steatohepatitis. That is a big term, but what it's colloquially known as is fatty liver. Fatty liver is increasingly being understood as a problem not just in patients with NET, but also the general population. But specifically in our patient group, what's important to know about fatty liver is we do have a predisposition to fatty liver when you have had a pancreatic surgery because it leads to a reduction in some of the digestive enzymes. And this leads to, again, fat malabsorption and it leads to fatty liver in around 20% of patients. There's also emerging evidence that there's an axis in the body, which is body fat leading to insulin resistance, which leads to inflammation, which leads to both fatty liver as well as neuroendocrine tumors. I think this is an emerging paradigm. We need to pay more attention to this, and we need to counsel people about this, and really very closely observe scans for the development of fatty liver and intervene as fast as possible, and ideally prevent it if we can. And some of the things that can be done for this are weight loss. 150 minutes of moderate intensity exercise is what's recommended. Avoiding calorie dense foods such as sugary drinks, fatty or greasy food, or ultra processed food, which have a lot of dense calories, and strength training. And this is true even if you have a neuroendocrine tumor or if you have fatty liver. I think this is also good for your overall health long term. So I do recommend people to really consider this if they have a NET diagnosis. Excessive cortisol is another hormone that can be produced due to something called ACTH, which is a master hormone that sometimes is produced by neuroendocrine tumors. Thankfully, this is rare, but it's mostly seen in lung carcinoids and very rarely in pancreatic neuroendocrine tumors. Some of the symptoms associated with this are weight gain, especially in the face, abdomen, upper back, thinning of the skin, leading to purple stretch marks, proximal muscle weakness. So some patients tell me, when they have excessive cortisol, that all of a sudden they are unable to climb stairs, which they could do, a few weeks earlier. There's also associated increase in blood pressure and blood sugar, thinning of the bones called osteoporosis, acne, hirsutism in women, and sometimes mood changes such as depression and anxiety. So thankfully, this is rare, but if you are having these symptoms, it's worth pointing this out to your doctor, your follow-up appointments. I want to pause a little bit here and spend some time talking about symptoms of anxiety and depression in neuroendocrine tumors because I think it's underappreciated and it would go a long way if we were better about identifying this and addressing this problem in our patients. So there's been some evidence beginning in 2011 and even earlier that neuroendocrine tumor patients have at least a 50% higher risk of anxiety or depression events compared to people without neuroendocrine tumors, specifically in the under 65 age group. And this was shown in a large database of 1,700 patients. More recent research, this one was done in the UK in 50 patients, which showed that 26% of NET patients had clinical anxiety on a validated scale. And more recently, in another study in China in 200 patients, they found that distress and anxiety is present in 30% of patients, depression in maybe around 15%, and some low resilience in 25%. The interesting thing about this is, and some people have asked the question, is this related to serotonin? Because we do know that serotonin levels are important for mood. None of the studies seem to point towards any kind of a correlation between serotonin levels or the presence or absence of carcinoid syndrome. So I encourage people, if you are feeling anxious or some degree of depression about your diagnosis, to really not to ignore it. Work closely with your clinical team in identifying it and treating it with professional help. Because I think long term, really being resilient and fighting the anxiety really helps you live longer and feel better. And that's the whole point of everything we're doing. And finally, the best treatment for any symptom related to neuroendocrine tumor is to treat the neuroendocrine tumor. Thankfully, we have a plethora of options, including surgical debulking or transarterial embolization. And we have more systemic options that go everywhere. So PRRT, capecitabine temozolomide chemo pills, cabozantinib, everolimus, and sunitinib. So we have an increasing number of options. Thankfully, the options are improving and increasing year by year. So there's been a lot of progress. And so if there is a large degree of symptom burden that you're suffering from, always thinking about, hey, can we do something about the tumor itself, is always the right question to ask. What matters most to control your symptoms and live life to the fullest? I would say focus on the positive, focus on the things that are in your control. Trust your clinical team, work closely with them. If you're having symptoms, mention them to your doctor. And finally, try not to Google your symptoms. That's all. Thank you for your attention.